So there is a degree of toxicity that comes with amivantamab because it's against EGFR. So you see some degree of EGFR-related toxicity, such as skin rash, paronychia. And you see also the MET-driven toxicity, in particular the edema. When you combine amivantamab plus lazertinib, there is another side effect, which is the venous thromboembolism. So when you start a combination, you always have to give 4 months of prophylactic treatment for thromboembolic events. I think that there are now regimens to aggressively treat the side effect and prevent them. It's called the cocoon regimen, where upfront, when you start the treatment, you start doxycycline, for example, which is an antibiotic that prevents skin toxicity. You also give some steroids if needed. So it's important to have an aggressive follow-up and management of the side effects. One of also I would say an uncommon side effect for the thoracic community is the infusion-related reaction that you see only after the first drops of the first injection of amivantamab. This is something that can be decreased, in terms of frequency, when you use high dose of steroids orally, dexamethasone 8 milligram, morning and on night, 2 days before you start the treatment. We will see probably a subcutaneous form of amivantamab, and this form prevents a lot the acute reaction after the first injection. For my colleague, I would say that in terms of toxicity management, there is, in my opinion, a key parameter to take in account. We are used to deal with EGFR-related skin toxicity because we used first, second generation EGFR inhibitors that were more toxic for the skin than third generation. But when you use a TKI, the half-life is very short. So when there is a tox, you stop the TKI and you're good for the toxicity in, let's say, 1 week, because you have a clearance of the drug that is very rapid. Amivantamab is a bispecific antibody with an half-life of around 11 days. So if you see some degrees of toxicity, you might discuss with the patients to stop the drug for a while and then resume the drug, and not wait too much to have a grade 2 or a borderline grade 3, because when you will stop the antibody, because of the half-life, you will still have some antibody in the blood for a few weeks, and then the clearance of the drug will be a bit slower than for the oral drug. So you need to navigate between that. When you have toxicity that rise, it's good probably to pause amivantamab, go on with lazertinib, till it decreases, and then resume amivantamab. This is something we are not so used. This strategy is not something that is very familiar in the thoracic oncology field.